So, very good morning to all. PRK haze is a major concern because it results in patient being unhappy after an uneventful surgery, and very little is understood about it. So, I will be basically dealing with the perfect PRK protocol that has been published by us, which can be used by the clinicians in their day-to-day practice, and we can have a better outcome. So, PRK is the first excimer laser procedure approved by FDA, less destabilizing to the cornea, suitable in thin, steep, and flat corneas. Then, why did it go out of vogue? It's probably because of the severe pain and the corneal haze postoperatively. So, let's recap wound healing post refractive surgery. Under a normal wound healing condition, the following the surgery, there's release of pro-inflammatory markers that cause activation of keratocytes. They get converted into myofibroblast and fibroblast, which apoptosize in time, resulting in a clear cornea with normal structure and function. But in altered inflammatory conditions post-PRK, there's excessive activation of keratocytes leading to formation of excess of myofibroblast and fibroblast that do not apoptosize in time, resulting in formation of an aberrant collagen causing haze. So we have published a work which shows that there's an indication of novel predictive factors that help that result in post-surgical corneal haze. We found out that higher PREX1 induced profibrotic factors in presence of TGF beta that resulted in predisposition to haze. So, we designed a unique approach wherein we studied the risk factors and then stratified patients on the basis of this risk factor to develop an algorithmic approach that we called the perfect PRK protocol to prevent and manage post-operative haze. So this is the risk scoring system involved in the perfect PRK protocol, which includes the OSDI. OSDI has a strong association with the corneal dendritic cell density, and which is an indicator of ocular surface inflammation. So high scores indicate high ocular surface inflammation, resulting in increased predisposition to haze. The second one is the vitamin D levels, which is strongly associated with high OSDI scores in dry eye. So it was seen that low vitamin D levels modulated nociception, increased inflammation of the ocular surface, resulting in increased haze and scarring. We also found out that vitamin D shows its anti-inflammatory beneficial effects by binding to the vitamin D receptors, and we found that there were reduced vitamin D receptors on the ocular surface in patients with dry eye. It was as a result of the hyperosmotic environment that degraded vitamin D receptors. So local vitamin D receptors was the real culprit. Our own data revealed that the patients with low levels of serum vitamin D levels had higher density of haze. We also found out that the impact of vitamin D receptors was there on the inflammation and haze impacted vitamin D receptors, and we found that in keratoconus, which is an oxidative stress condition, low vitamin D levels was associated with high MMP9, which indicated high levels of ocular surface inflammation. The next one was contact lens intolerance. Chronic contact lens use stimulated the cascade of pro-inflammatory responses, resulted in contact lens intolerance, which caused an unhealthy ocular surface and resulted in ocular surface inflammation. We also found out high levels of MMP9 and pro-inflammatory interleukins in the tear film of patients with contact lens intolerance. The next one was meibomian gland dysfunction, which correlated with the ocular surface inflammation, and hence high gland dropout and low T-BUT were given high scores, indicating high risk to develop haze. Working environment also had an important role, and because of correlationship between the ultraviolet radiation level and the incidence of late onset corneal haze after PRK. So finally, the risk scoring system divided the patients into low risk, moderate and high, with less than 5 score as low risk, 5 to 10 as moderate, and more than 10 as high risk. So we designed a stepwise approach to manage the patients undergoing PRK surgery to decrease the risk of development of haze. This is a regimen that we use on a day-to-day basis to prevent the PRK haze. Pre-operatively, patients with low risk, that is less than 5, are taken for surgery. Patients with moderate to high risk are treated with tablet doxycycline BD for 15 days, steroid eye drops tapering over 4 weeks, cyclosporin eye drops over 4 weeks, and vitamin D, if less than 10, are given treated with injectables, or otherwise they are treated according to the WHO guidelines. Intraoperatively, loose epithelium and excessive secretions indicate inflammation. So we put ketorolac soaked BCL immediately post-operatively because ketorolac reduces pro-inflammatory markers and thus helps in optimizing wound healing. The post-operative treatment regimen includes use of steroids, that is low-potency steroids like loteprednol, tapering over 8 weeks. Then sodium hyaluronate eye drops 2 hourly for 6 months, and vitamin D is treated according to the WHO guidelines. This is for low risk patients having a low risk score that is less than 5. For patients having a high risk score more than 10 are treated with tablet doxycycline 100 mg BD for 15 days. High potency steroids like eye drops prednisolone tapering over 4 weeks, followed by low potency steroids like loteprednol eye drops tapering over 8 weeks. Sodium hyaluronate eye drops 2 hourly for 6 months, cyclosporin eye drops BD for 6 months, and vitamin D is treated according to the WHO guidelines. So this prediction, examination, intraoperative treatment, post-operative treatment and follow-up, evaluation and chronic treatment, that is the perfect PRK protocol, helped us in managing PRK and improving the outcomes post-PRK surgery, reducing the incidence of haze. Thank you.
Thank you, Dr. Sneha. So, if the audience would like to ask any question. Okay, so in which patients like you get clinically significant haze for a long term, they're steroid resistant and they're responding to steroid with a high IOP, what do you suggest for those patients?
So we plan to reduce or change them to low potency steroids. We taper them faster and we start them on anti-glaucoma drops. Along with that, we increase the duration of cyclosporin and then we follow them up to check for IOP.
Yeah, thank you. Any tacrolimus involvement?
Only if the patient is not responding to cyclosporin, then we add tacrolimus. Initially, we don't.
Yes. Thank you.
Thank you.
I have one question. Which day do you remove the bandage contact lens?
So we see the patients every day post-operatively, day 1, day 2 and day 3. Generally they heal by day 3 and after the epithelium has healed completely, we remove the contact lens on day 3. We might change it every day if the patient is not very comfortable with it. Sometimes there might be a debris on it. So we change it if the patient is not comfortable or if we feel that there is a need to change. And otherwise we remove it on third day.
So there's no difference between the 3 grades for all the patients. It is on day
it is
3.
third day. If they have not healed on day 3, then we
only
call them up on day 4 and day 5 and remove them accordingly. We make sure that the epithelium has healed completely.
Thank you.